Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. This week is a great delight to have two speakers. We have first Ross Su from the National University Hospital in Singapore to talk to us about current concepts in the systemic treatment of thymoma. And we have Dr. Ria Shah from Maidstone, a very prominent medical oncologist in London, to be able to answer some questions and engage in discussions. Remember, all this is Premier Education brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. And without further ado, I'm going to let Dr. Ross Su take the floor.
I'd like to thank Professor Eric Lim for giving me the opportunity to present at the Royal Brompton Hospital Virtual Grand Rounds. I apologize for not able to present in person due to a conflict schedule. The title of my presentation today is Current Concepts in the Systemic Treatment of Thymoma. Here are my disclosures. Here's my overview. I'll be basically talking about systemic therapy, the use of chemotherapy and other systemic agents in the curative intent setting, use of systemic therapy in the advanced stage setting, as well as future directions. Firstly, let's start off with a case. This is a 43-year-old man. He initially presented with chest pain. He has no other prior significant past history. So he had a biopsy done, which was shown Thymic carcinoma. The patient underwent neoadjuvant carboplatin and paclitaxel over 3 cycles, and he underwent curative intent surgery in the middle of 2020. The disease was staged as a YPT3 and not. The patient went on to have post-operatively had concurrent chemotherapy in the form of cisplatin plus radiation therapy that completed in September 2020. Unfortunately, he recurred in August 2022, and you can see here on the PET scan the presence of recurrence. He received 3 cycles of chemotherapy with carboplatin and paclitaxel with disease progression. At that time, he had next generation sequencing done using Foundation Medicine platform, in which he had a couple of important genetic findings. Mainly at a high TMB of 21 mutations per megabase, and interestingly, he also had MTAP deletion as well. So based on the high TMB, he was offered an immune checkpoint inhibitor in the form of single-agent Pembrolizumab, and this was started in November 2022. These are his scans. You can see a mild FDG reduction at the time, and he was still on treatment as of July 2025. So this is a case of a patient who had neoadjuvant chemotherapy followed by surgery, then had recurrence and had systemic therapy with chemo, and then subsequently in the late-line setting, pembrolizumab. So thymic epithelial tumors are quite rare, and they're histologically heterogeneous tumors. As you can see here, the incidence of malignant thymomas is only about 0.14 per 100,000 per year in Europe. And thymic cancer, even further, it's even rarer at 0.01 per 100,000 per year. And survival was obviously malignant thymomas have better survival than thymic cancers. Thymic epithelial tumors are histologically heterogeneous, metathymomas, squamous cell thymic carcinomas, as well as small cell endocrine tumors as well. And they have mainly, apart from for example, my case had high TMB, but generally speaking, especially thymomas, they have low TMB and very limited titer genomic alterations. Thymic epithelial tumors are associated with autoimmune disease. In particular, it's associated with myasthenia gravis, and in this particular presentation was presented at ESMO, about 70% of patients had, in terms of autoimmune disease, presented myasthenia gravis. They tend to be younger patients, female, European, and associated with thymoma subtype B2. Autoimmune disease is quite rarely seen in thymic cancers. Prognostic factors for thymic epithelial tumors, the complete resection is obviously prognostic, as shown here in the Kaplan-Meier survival curve. The stage disease and also histological subtype, as I alluded to before, thymomas tend to do better. And in this particular study, the five-year survival was 82% versus thymic cancer was only 48%. So some of the key points in the systemic management of thymic epithelial tumors, a multidisciplinary approach requiring input from pathology, radiology, surgery, radiation, as well as medical oncologists and the paramedical staff as well. Thymomas are chemosensitive. The preferred first-line regimen currently is cisplatin with doxorubicin and cyclophosphamide, also known as CAP. For those patients who are not fit for CAP, alternatives include cisplatin and etoposide or carboplatin and paclitaxel. Immune checkpoint inhibitors I will mention later, but associate high risk of toxicities and may be considered in the context of a clinical study. Thymic cancers are more aggressive and have poor prognosis. The preferred regimen in our institution is the use of chemotherapy in the form of carboplatin paclitaxel with or without an anti-angiogenic agent such as ramucirumab. Immune checkpoint inhibitors are active but have high rates of immune-related side effects. To use the adjuvant systemic therapy is controversial, and that involves a multidisciplinary discussion, taking into account high risk factors such as the higher stage, incomplete resection, presence of solitary or pleural metastases. So how do we decide about the use of systemic therapy? So this is the ICNIC definition. It can be the systemic therapy, can be primary chemo, and this is basically used as induction therapy for patients who have a plan for subsequent curative intent surgery or radiation, but at the time have unresectable locally advanced disease at the time of diagnosis. So a bit of induction therapy may help proceed with local therapy with curative intent. Two other forms of systemic therapy can be just systemic therapy with no plans for curative intent therapy. So that's exclusive, just straight up systemic therapy, and also systemic therapy if the patients have recurrence after curative intent treatment. Right, so let's start with primary chemotherapy, and this for patients with unresectable or locally advanced disease. The intention for these patients is curative intent, and the use of primary chemotherapy is to enable R0 resection with clear margins. The most commonly used regimen in this French database was CAP, which is used in about 70% of primary chemotherapy. And the outcomes, and this is based on a meta-analysis, the outcomes response rate was around about 60%. And in those who underwent surgery, complete resection was reported in 73%. 10-year survival rates were excellent, with 10-year survival of 76%. Right, so this is a list of phase 2 studies of the use of induction chemotherapy in thymic epithelial tumors. As you can see here, it's associated with high responses, ranging between 60 to 90%. R0 resection is also quite high as well. And more modern chemotherapies using cisplatin docetaxel is associated response rate of 63%. And the Italian study of etoposide groups and response rate of 100%. But mind you, the sample size is very low, 7 patients only. Right, so this is a guidelines from NCCN about patients with locally advanced disease. If they're potentially resectable, they undergo primary chemotherapy and they are restaged. If they are resectable, then obviously they undergo resection and may consider post-op radiation depending on the pathological findings. If they still remain unresectable, then the patient will undergo radiation with or without chemotherapy. Right. There are other novel approaches apart from just using chemotherapy as induction in patients prior to surgery or radical intent radiation. And some of the approaches involve giving chemo plus concurrently with radiation. A couple of trials have explored that. The responses are around about a high 40% mark, and around about 70% of patients to up to 95% of patients underwent surgery and are not was reported around about 80% of patients. PAF-CR rates was around about 17% of patients. More recently, and I'll go into more details in the next slide, is a Korean study of using neoadjuvant chemotherapy with immune checkpoint inhibitors for patients with Thymoma or Thymic cancers for 3 cycles, followed by surgery or radiation treatment, followed by another 2 years of immune checkpoint inhibitors. So what are the results of this Korean study? So this is basically the flow chart: 3 cycles of chemo plus pembro. If they're resectable, they get surgery. Patients who are unresectable or have R1 or R2 resection, they undergo radiation. And following the completion of either surgery or radiation, they get 2 years of pembrolizumab. The results are in patients that underwent surgery, major PAF response was 46.4%. PAF complete response rates was 18% in those who managed to get surgery. Overall response was about 57%. There were 5% of treatment-related deaths. These were patients, 2 patients who passed away because and they had Thymoma, and it was due to immune-related toxicity. In particular, they had a grade 5 myocarditis. 30% of patients did not receive surgery after receiving a neoadjuvant chemo immune checkpoint inhibitor. So interesting results, but not ready for prime time. All right, moving on to systemic therapy for metastatic disease. These are for patients who are not for curative intent, and so there are various agents available. Commonly used agents, especially in Thymoma, is CAP, as mentioned before, cisplatin, doxorubicin, cyclophosphamide. There's also VIP for patients who may not be fit for anthracycline-based chemotherapy, and of course, carboplatin and paclitaxel are also used as well. So responses in with CAP, 50% response rate, and time treatment failure is 18 months. That's a commonly used regimen. In the French database, about 2/3 of patients received that. Another favorite, I guess, is carboplatin paclitaxel, and with a PFS around about 16.7 months. With Thymomas, much lower with thymic cancers, PFS of 5 months. And moving on, and I will just talk about anti-angiogenic agents for intent systemic therapy. There are lots of agents. Monotherapy agents initially were used, such as sunitinib and lenvatinib. These are some of the studies, and the response rate is pretty low in some of the cases, highest with lenvatinib and papatinib, around about 40%, and around about 20% with sunitinib in one particular study. And finally, in combination with chemotherapy, such as the Italian study with the RELEVENT study, the chemo plus Ramu, or the Swog study from the US of chemo plus Ramu. Again, that's a randomized phase 2 study. The RELEVENT study showed a response rate 80%, and in the Swog 1701, it was similar response rate about 88%. But however, the study was stopped prematurely because of challenges with enrollment. So the RELEVENT study, this is the Italian one. This is the single-arm study of chemo plus ramucirumab. So again, I mentioned response rate 80%. For patients with either thymic cancer, Thymoma type B3, the progression-free survival was 18 months, and overall survival was 52 months. Right, I mentioned before, this is the Swog study, randomized study. Again, they didn't meet the primary endpoint, and the study was closed because of poor enrollment. This is the only randomized study using chemo plus or minus anti-angiogenic agents. Okay, so moving on to immune checkpoint inhibitors. So basically, the role of immune checkpoint inhibitors, the main questions are: is it effective and is it safe? So this is a study, a meta-analysis of all the monotherapy trials, and in conclusion, the responses are a little bit higher in patients with Thymoma at 33%, a bit lower with thymic cancers. However, the grade 3 immune-related toxicities is unacceptable for patients with Thymoma. 58% of patients have grade 3 immune-related toxicities, slightly lower with patients with thymic cancers. And So, my take on this meta-analysis is that in patients with thymomas, I would not be using immune checkpoint inhibitors. It's unsafe. Outside of clinical trials, it shouldn't be used at all. In thymic cancers, the activity is a bit is lower than average, but it can be tried out and should be used with caution. Right. So this is some of the trials that examine the use of upfront immune checkpoint inhibitors in combination with chemotherapy. Focus on the MARBLE study from Japan. This is basically using carboplatin, the backbone of the chemotherapies in the advanced setting, with an immune checkpoint inhibitor in the form of atezolizumab. So here you can see the response rate is about 56%, PFS 9.6 months. 2/3 of patients have severe immune-related toxicities, hence highlighting the risk of exposing patients with thymic cancers or thymomas to immune checkpoint inhibitors. So in further details, about 47 patients, they had chemo plus atezo, and then had maintenance atezolizumab up to 2 years. So the primary endpoint of the study was response rate, and the response rate was 56%. The progression-free survival was the secondary endpoint, and was 9.6%. Just to highlight that all patients had at least any grade immune-related toxicities. So, and the commonest ones were skin disorders, and that's seen around about 72% of patients. 2/3 of patients, as mentioned before, had grade 3 or more immune-related toxicities, and they're mainly hepatitis or skin-related immune-related toxicities in terms of the grade 3. But you can see there are many different types of immune-related toxicities. Could be hepatitis or colitis, pneumonitis, and sometimes even myositis, as well as myocarditis in other patients. Right, so a few of the directions. It's quite tricky in the research for thymic epithelial tumors because it's quite rare, as I mentioned before. And because of the rarity of the disease, there's lack of high-level evidence because it's quite challenging to randomize trials. Like I mentioned before, the Swog study, the enrollment was poor and the study had to stop. The biology of the thymic epithelial tumors, because of the different types of thymic epithelial tumors, ranging from the different subtypes of thymomas to thymic cancers, there's a lot of heterogeneity in terms of the histology. There's also a lack of preclinical models in terms of therapeutics, because of the lack of high-level evidence. There's also regulatory barriers, and it's quite challenging to get approvals and based on a single-arm small studies. The lack of predictive biomarkers, and also the use of immune checkpoint inhibitors, which is quite prevalently used in other solid tumors, is quite constrained in use of thymic cancers because of the high risk of immune-related toxicities. So, overcoming the challenges that are facing the approach to thymic epithelial cancers, we need multidisciplinary approach, the use of cancer registries, and there are some around globally. The clinical trials, we should try to put as many patients as possible in clinical trials, international collaborations with professional societies, patient groups, industry and regulatory bodies, use of innovative therapeutic strategies, which I don't have time to go into, but use of cytokines, antibody drug conjugates, targeted therapies, which I didn't speak about, immune modulators, use of novel study designs with maybe an external or synthetic control arm, adaptive design, or share the common protocols among different regions, and finally, correlative studies as well. So, in conclusion, thymic epithelial tumors are rare. They're histologically heterogeneous tumors with different biology and different prognosis. Thymomas are exclusively chemosensitive, and the preferred first-line therapy is cisplatin, doxorubicin, and cyclophosphamide. The recommended first-line treatment for thymic cancers in our institution is carboplatin with ramucirumab. Immune checkpoint inhibitors are active, but it's associated with severe immune-related adverse events. A multidisciplinary approach and a multi-stakeholder collaborations are crucial in enhancing clinical outcomes. Finally, and improvement in our understanding of tumor biology and developing biomarkers are required to improve patient selection for treatment. Thank you for your attention.
Amazing. Thank you very much, Dr. Ross Su, for an amazing presentation. Riaz, I'm always so impressed by how fast the field of systemic treatment goes. And previously, I wasn't, or our MDTs never really used very much systemic treatment, either in the induction period for thymomas. Normally, we would say, is it resectable or not resectable? And if it's not resectable, they go down the systemic treatment route. I mean, your experience in your MDTs, what proportion of patients do you reckon would respond to systemic treatment to make them potentially operable?
Oh, I think the response rates to chemotherapy are quite high. And I think fundamentally the issue is around that initial MDM discussion on resectability. And I think one of the things we have to accept is that the definitions of resectability are not black and white. They are somewhat variable, and the individual MDT can make different decisions. Different MDTs can make different decisions over time as to what is and isn't resectable. And even an individual surgeon over the course of their career can alter in their thinking on what they feel is resectable or not resectable. So a lot of this is in the eye of the beholder, but it's a critical step in patient management. That initial MDM discussion, this is or is not resectable, really does dictate exactly what treatment paradigm the patient goes down. So I do think we need probably to think about making sure we do optimal imaging of these things, so that we map out exactly where the disease is, and we get systems in place for not just a single surgeon's opinion on resectability, but a team. You know, many MDTs may have just one surgeon. And what these patients, I think, benefit from is multidisciplinary opinions from not just one oncologist or one surgeon, but a team of surgeons and a team of oncologists.
Okay, thank you. Mr. Adrian Marchbank is asking, why is the risk of toxicity so high with immune checkpoint inhibitors in the setting of thymoma?
Well, I presume it's to do with the fact that your thymic gland is a key progenitor of your immune system, and the cells involved are sort of pre-armed, they have a propensity to cause immune-related toxicities. Your thymic gland is critically involved in immune cell development and the development of tolerance of self versus not self. And I'm sure that giving immunotherapy abrogates that. I suspect that's what it is, but I don't know for sure.
Okay, that's interesting. Question from Professor Paul Bass, probably to me. Is there a recommendation for the use of robotics or other forms of surgery? And the short answer, Paul, is whatever you can get to achieve complete clearance. I personally use single incision, subxiphoid, minimally invasive surgery to allow my patients to go home on the same day. And they are best for smaller tumors, centrally located, or single port VATS on either side. And if not, open surgery. From a surgical point of view, technical R0 resection is the most important point, followed by access. So that's how I would address that. Got a question from Dr. Abil Jalil, who's asking, if you have bilateral pleural deposits in thymoma, Riaz, in your experience, would you still consider induction systemic treatment and then restaging with a view to potential surgery?
Well, I think really fit patients effectively often end up having, let's just call it trimodality therapy. They will end up having, at some point in the course of their illness, an operation, potentially radiotherapy, and definitely systemic therapy. So I think you see a patient with bilateral pleural deposits, they've got, stage 4 disease, they're going to get systemic therapy. Now, what may happen as a result of that systemic therapy is varied, and there will be cases where you could then justify quite aggressive approaches. If the pleural disease completely responds and becomes indolent, then you may well revisit the idea of resectional surgery. I mean, there are even cases where patients have had their tumor masses resected and even pleural deposits resected. Whether that translates into cure, I think is debatable.
Yeah. Dr. Addy is asking, do patients with myasthenia form a subset for which you may or may not consider systemic treatment?
Well, the myasthenia is always an issue in terms of, you would be very, very careful, for example, about giving immunotherapy to someone with a myasthenic syndrome. And, just outside of thymic cancer in normal life of using immunotherapy in lung cancer, where we use huge volumes, we do see things like triple M syndrome and myasthenic crises. And it's usually quite a dramatic thing, and patients can get life-threateningly unwell. So I think the myasthenic scenario alters thinking in terms of the types of drugs you'd use. And I think it's a poor prognostic marker of a more aggressive disease. But the treatment algorithms that Dr. Su outlined to us would largely be the same.
Excellent. And on that note, Riaz, can I ask, in UK, we don't really have Thymoma or thymic epithelial tumor guidelines. What's your view on, of course, globally, there tends to be a shift towards the US NCCN guidelines. Do you think that's applicable to the UK and European settings?
Well, I think NCCN guidelines are peer reviewed and they're referenced, and every regimen that appears in the NCCN guidelines has at least a clinical trial. It may not be randomized, it may be a single arm phase 2, but and they're all reasonable options. And I think, we've seen from the data Dr. Sood presented, some of these patients have quite indolent disease and live for many years and may intermittently have chemotherapy through the course of their life. And you run out of options. So, you start with the things that you think are most likely to work, and you just go down the list gradually. And there's a whole range of options, including things like somatostatin analog treatments, everolimus. There's all sorts of combinations that you will see. Single agent pemetrexed is quite active. So I think it's a case of it's individualized care based on a patient's performance status, based on a patient's velocity of disease and their needs and wants and what they can tolerate. I think most of us would agree multi-agent chemotherapy is probably optimal. We would use PAC or carboplatin paclitaxel. Ramucirumab isn't reimbursed in the UK, but the data is very good from the trial that Dr. Su showed us. And then gradually you would work down the list of NCCN guideline list. So I actually think it's quite a nice little summary of active known agents in this disease.
Excellent. Thank you so much. As always, there are so many questions and not enough time for answers. Next week, we're going to look a little bit about radiotherapy in thymoma with Professor Keith Kengel from University of Pennsylvania, which leads me to thank our sponsors, AstraZeneca, Medtronic, and Medela, the sites of care, and also for a fantastic talk by Dr. Ross Su and fantastic discussions, Riaz. Thank you so much for joining us today. Goodbye.